As we go through here, I am a pathologist, so we're really into sort of gruesome pictures. We eat lunch and look at gruesome pictures a lot of the time. So if you don't like gruesome pictures, just cover your eyes while they're there, just to give you a little bit of warning. But I just wanted to say that veterinarians and veterinary diagnostic labs and their diagnosticians, including veterinary pathologists, play a huge role in safeguarding the public from diseases that not only affect our livestock industry, but also humans in regards to zoonotic diseases. Probably the best known example is West Nile virus, which can cause fatal encephalitis in people. This virus first entered the US in the 1990s through New York, but it was first identified by a veterinary pathologist. So when you think human health, you also need to think about veterinarians in the scenario. Most veterinary diagnostic labs are located in association with either colleges or schools of veterinary medicine. Hence, they play a role, a pretty important one, in training of veterinary students. And this is usually, for the pathology portion of it, through necropsy, AKA postmortem examinations or autopsies for you medical people. Here at UGA, our senior students do a 3-week rotation in pathology. And so every afternoon, starting at 1 o'clock, they are doing necropsies on a variety of animals, anything from a mouse to an elephant. So because of this sort of thing that we do with the students and how this case came about, which actually was something that was necropsied by a senior student, I thought we'd do a little play acting here. So I need 3 volunteers. Justin, you're one of them. It's bad when you know the name. Dr. Harris is the next one. So you have to come down front. Who wants to be the third? Okay, Dr. King. Okay, you're right here, Justin.
Okay. All right.
You're Mike.
Oh, okay.
There's your script.
Excellent.
In the middle. In the middle. You're Coco.
Sorry, Chris, I couldn't help it. I'm Coco.
You're Coco. And you're Bovia.
Okay, thank you.
There's your script. Okay, so Mike and Coco and Bovia. Did you get it? Mycobacterium bovis. Okay, so when our students come down to necropsy for the afternoon, we first meet in a conference room. And so they meet with the resident that's on duty and also the faculty member. And we go over the cases for the day. So it goes something like this. Good afternoon, everybody. How many cases do we have today?
We have 5 cases today. 3 dogs, a cat, and a steer. I heard a horse may come in later.
Okay, sounds like a pretty busy day, so we better get busy. Mike, let's start with your case. What have you got?
I've got a 2-year-old male neutered golden retriever. The dog was under treatment for chronic ehrlichiosis. He was imported from Turkey about 3 months ago. He was euthanized because of end-stage hepatic disease, noted on ultrasound about 12 days ago. It looks like that before he left Turkey, he was vaccinated for rabies 2 months before importation and for distemper, hepatitis, and leptospirosis and parvovirus about a month prior to importation. Oh yeah, also Bordetella a couple weeks ago, prior to importation. He also got a dewormer on the day of importation.
It also looks like, from the clinical history and ultrasound report, it looks like the dog was first presented to the veterinarian about a month after importation for weight loss and poor appetite, at which time blood work would have been done because he had increased globulins.
Speak up, please. That's not a PA.
Got it. Yep. But the ultrasound report describes a complex and non-typical periportal vascular nodular disease with acquired portosystemic shunts and enlarged hepatic lymph node. Their differentials based on the ultrasound were liver flukes, not certain what fluke they were talking about, maybe Nanophytes salmonella, Ehrlichia, heterobilharzia, and fungal disease.
Hey, the dog came from Turkey. Apparently, the wealthy used to have golden retrievers as a status symbol, but when the economy tanked, many were released and they are now feral in Turkey. Some group, maybe more than one, is importing these dogs, so maybe another differential would be visceral leishmaniasis should be a differential diagnosis.
Although the dog is young, with multiple nodules in the liver and an enlarged lymph node, what would be some other differential diagnoses?
Maybe neoplasia, like lymphoma.
I agree, but I'm not certain what flukes occur in Turkey or if they have heterobilharzia or even fungal diseases which are common there. I guess we have a lot of research to do assuming whatever the dog has started in Turkey. Anyone know the regulations for importing a dog?
I think maybe they need to be vaccinated for rabies and have a health certificate saying they are in good health.
I think you were right about the importation requirements, but I guess we all need to look that up and make sure. Well, I like our differential list for now, but we better get started. So, the volunteers can sit down. So we're going to go out onto the necropsy floor. But to do that, we have to put on our PPE. Okay, so our standard PPE is an apron, which is always too long for me. We always put on boots. There's a lot of blood in the necropsy room. What else do you think I need? What's that? A mask? Well, we don't typically wear a mask. Well, the only problem with a mask I find is that I don't know who's under the mask. And when you're teaching, it's difficult to be a good teacher when you don't know if they're going to faint, or if they're happy, or if they understand you just based on the eyes. And then when it comes to grading, you haven't the faintest idea who was under a mask and who's really getting the A or the B. So we don't always wear masks. We've been fighting that. But gloves, right? A face shield. We sometimes wear a face shield, and we'll talk a little bit about that. Usually when it's something that, like rabies or something like that. But our other standard equipment is going to be a knife and a striker, and we'll talk a little bit more about that. Okay. So usually when we're down on the necropsy floor, we can have anywhere from 1 animal to maybe 10 animals. And so there's anywhere from 5 to 10 students down there, and so we'll be doing multiple things at one time. So this is our necropsy floor here. This particular day, there were 3 animals being necropsied. The day in question, the animal that actually had tuberculosis, we actually had 5 necropsies going at the same time. So we have to keep track of everything going on at one time. So this was the dog in question. Doesn't look very much like a golden retriever anymore. He's extremely thin. And even though he's got yellow fur, you can actually see that his skin is also yellow. So he's icteric. So our first thought is that he has liver disease. And we sort of knew that from the clinical history that came with the dog. And when we opened up the dog, he was a little bit autolyzed. So we had some postmortem decomposition going on, and that's a little bit why the lungs look like that. But you would mostly, in an animal that had tuberculosis, you might think that the lung would be involved. The lung was not involved in this animal. The primary lesions were in the liver, and you can see multiple nodules in the liver here. Little closer view of these nodules. There are multiple sizes. And then this is the hepatic lymph node that's been cut open. So it had a very large hepatic lymph node. And then on the ultrasound, they hadn't noticed it, but at necropsy, he also had white nodules in the kidneys. So these are the kidneys of a dog. And so at this point in time, our differential was sort of like this. Whoops, we're going to get to the striker. So when we take the brain out on an animal, we often use a striker. So, and we'll get back to why that's maybe important. So at this point in time, our differential diagnosis is what our vet students, when they learn general pathology, learn as NAG. And that equals neoplasia, which in this case with multiple white nodules. Lymphoma would be really high up on your list. And particularly in a golden retriever, too, they have a high incidence of lymphoma. Abscess, and at the time of necropsy, one of the ones I was thinking about was actually rhodococcus. And then granuloma. And usually when we see granulomas in a dog, we're thinking of some sort of fungal disease. But then it's like, so what fungi occur in turkey? But the fungus and the granuloma were really high up on my list at this point in time. So initially, after necropsy, I submitted tissue for fungal culture. But when I got the histopath back, in the liver, there were these coalescing areas of necrosis and inflammation, not really looking like a typical granuloma, but it was definitely not neoplasia, so that got whacked off the list. And then histologically, most of what was there in the liver was actually necrosis. And so this is what it sort of looked like, no cells left in the area. That hepatic lymph node that was involved looked very similar, a lot of inflammation and necrosis going on. And it wasn't until I looked at the kidney that I really got the impression that I was working with some sort of granulomatous disease. So this is a histologic section of a kidney with multiple granulomas in it, sort of obliterating the parenchyma. And then actually in the meninges, there were actually multiple little granulomas in the meninges. And so at this point in time, I requested some special stains. So again, because fungus was still sort of high up on my list, even though I didn't see any, I got a fungal stain. I also did a Giemsa, which is my sort of standard stain when I'm looking for any sort of pathogen. It will stain up fungus, bacteria, anything you want it to stain up. And then I really haven't the faintest idea why I did an acid fast at this point in time, because to be quite honest, mycobacteriosis was not on my list for this dog. But for, I don't know, maybe I had a flash of inspiration. But this is the kidney, and one of the granulomas has many, many acid fast organisms in it. And then this is the liver. And it was just packed full of acid-fast bacteria, which made me really worried. And it's like, oh my gosh, why are there so many usually we have to hunt for them. So mycobacteriosis in animals in the US is really not all that uncommon. We see lots of M. avium in birds. That's a really common thing, particularly in pet birds. We see paratuberculosis in cattle and small ruminants. That's really common. We see a lot of atypical types of mycobacteriosis in cats and fish, amphibians, and even reptiles. We see M.bovis very rarely in very limited areas in cattle and wildlife, but we don't have any in Georgia. And then in dogs, mycobacteriosis, in my experience, is really uncommon. And mycobacteriosis that actually is a tuberculosis type, I have never seen in 40 years that I've been doing pathology. So in dogs, it's really rare. So it really made me worry about what I was actually looking at. So I said, oh no, and I ran down to the micro lab and I said, well, maybe we shouldn't continue the fungal culture on this one. It's probably not a good idea. And then I asked for a mycobacterial culture, and then in the lab they suggested that we go ahead and do a PCR for a quicker identification of the organism. And when it was sequenced, it came back as being either Mycobacterium tuberculosis or bovis. And then with further testing and sequencing, it came out to be Mycobacterium bovis in this particular case. So that came down to, okay, so we really didn't anticipate this in necropsy. And so we started hunting down and trying to figure out who actually had been exposed to the organism. Thankfully, in Dr. Sanchez's lab, they do everything under a hood, so there really wasn't any real exposure there. But there was exposure on the necropsy floor. There was one veterinary student who did the necropsy. There was a resident who was roaming around looking to see what was there, and myself. Those were probably the three that were most exposed to the agent while we were down there. So this also led to a review of our biosafety procedures, including the use of the striker that we typically take a brain out with. And also it stemmed and got into what kind of disinfectant were we actually using in the necropsy room. So the people that were exposed, we all went in for immediate TB testing. Now, you could only suggest it to the students. You couldn't make them go do it. So I really have no idea how many students really went and got tested. I do know that myself and the resident on the case did get tested. One of us became reactive. And in a previous case with Mycobacterium tuberculosis type of agent, out of another veterinary school where a number of people were exposed, a number of them actually became reactive on the TB test. And they actually traced it back to thinking that maybe it was the striker saw that was the problem. And I could see in our case that maybe a striker could have been a problem because the dog had granulomatous meningoencephalitis sort of going on. So the striker probably was not a good idea in that case. So some of the biosafety changes that we made, we decided that if there were any imported animals, this animal came from Turkey, and so we decided if there were any imported animals, only residents and faculty members would do the necropsy on those animals. Besides our routine PPE, we were adding a face shield to the mix. It's typical of what we do for, we see actually a lot of rabies. And so when we have a suspected rabies case, we always wear a face shield. Or the animal can be done in a biosafety cabinet. But that will only work for little animals, maybe up to the size of a cat. But past that, we're really going to be doing it on a table. And then, of course, no aerosolizing equipment. So that sort of takes out the striker from it, and it also takes out the bandsaw. And I think one of the reasons I love being a pathologist is because I love power tools. And this just breaks my heart that I can't use the bandsaw. But this is just for animals that we suspect something like this on. And then these animals coming from foreign places, we are going to double bag the carcasses and use appropriate disinfectant that actually kills tuberculosis organisms. And then the animal will not be released to anything until we figure out whether it has infectious disease or not. So those are some of the changes that we made in our SOP for biosafety. And then we did replace our disinfectant with one that actually kills Mycobacterium. Before that, we were using something called lemon Q that does not do the job. So this dog came from Turkey. And so I went in and I was looking at, what's the incidence of tuberculosis in Turkey. There's really not much in animals reported in the literature or that I could find on the internet, but there's a lot in humans. So this is sort of in 2011 cases, human cases. And Turkey is where the star's at, for people that don't know their geography. And you can see that it's in sort of one of the lighter blue areas, so there's not a whole lot there. But tuberculosis in Turkey is considered highly endemic in humans. Most cases are Mycobacterium tuberculosis, with a small percentage being M.bovis. And those people with M. bovis usually are getting it because they're working with animals with M. bovis. I did find a few statistics about cattle. It was usually by province to province in Turkey, and so in this one study they had about a 1.5% incidence of Mycobacterium bovis in their cattle. It could potentially be that in other areas it's higher than that, but I didn't find it for the whole country. So M. bovis is a little bit different than tuberculosis. It's transmitted from animals to humans, and very rarely from humans to humans. Usually it is ingested, and so usually the gastrointestinal tract is involved in people that end up with M. bovis, and it's usually from the consumption of raw milk. It can also cause a respiratory disease, and that's usually with droplets from infected animals. Mostly in people, M. bovis causes extrapulmonary infection though, and again, that's from the consumption of contaminated milk. And I think maybe this might have been the route in our case. We have no idea where this animal actually came from, what its history is or anything, but considering the distribution in the liver and the hepatic lymph node, I think maybe it was an ingested organism, and maybe it was on a farm where they were either giving the dog milk that was contaminated and wasn't pasteurized, or maybe an animal died and it got it from eating one that was infected. So what about this importation? I knew nothing about importation of dogs from Turkey, or even that it was a big problem. And it's not only Turkey, they're coming from all over being imported, actually. CNN has, if you go on, they have this little video that goes through it, and it almost glorifies it, which I find a little disturbing. Like it says here, adopt a golden, Atlanta works to bring golden retrievers abandoned in Turkey over to the US for a chance at a better life. We have plenty of animals here that need a better life. We don't need to be importing them. So there's a lot of different things on the internet talking about this, and a lot of it is this adopt a pet sort of thing, but a number of people think this is actually a scam. So they're bringing these animals in, they're selling them to different places for a profit, and then those people are selling them to other people for a profit. And so even though this dog was imported into Georgia, it potentially could have been sold somewhere else in the United States and actually could have disseminated this further than Georgia. So what are the requirements for importation of dogs? It's very limited, actually. CDC requires that they have that they're healthy and that they're vaccinated for rabies. And of course, rabies is a concern, but I actually think there's probably other things that are probably more of a concern than rabies coming into the country. We're usually heightened awareness that a dog might have rabies, whereas some of these other diseases like Mycobacterium bovis is not something that was even on my agenda. I've never seen a case. It's my first case. I hope it's my last case, because it caused a lot of concern on everybody's part, and it took a lot of time trying to figure out what it was, who got exposed, what are we going to do so that it doesn't happen again. The problem is with something like this is that it's all well and good. It's been like 3 months, and our expectations are up here that we're going to remember that something that looks like that's tuberculosis, but maybe in 3 years we've forgotten about it. So we have to be ever vigilant. Dogs can be denied entrance if they don't look healthy, and then they have to get a health exam. I can't imagine this dog looked healthy when it came in. I think it probably was already thin, so I'm not certain at the ground level how much these animals are really looked at and how this is actually, they probably just look at their health certificate, and who did the health certificate probably don't know because it's from Turkey, and that it's rabies vaccinated. I don't even know if they perhaps even look at the animal to see if they look healthy or not. You can import dogs from non-rabies area without vaccination, but there's almost rabies in almost every country in the world. So I just want to thank Dr. Sanchez and her group. They were very instrumental in pushing forward and actually getting a diagnosis of the correct bacteria. And then Kathy Brown, another pathologist, facilitated getting the tissue sent off for identification confirmed. And then Dr. Sakamoto and Michelle Norris is our quality control people, and others. We worked together trying to revamp and implement new biosafety protocols. It's always hard. People push back a lot. I'm sort of a minimalist. And I asked the question about whether you wore a mask while you were examining a person. I think a physician probably is more likely to get something from an animal or from a human by just examining them than we will from an animal doing a postmortem examination. When we do postmortem examinations, there are certain diseases that are really transmissible. And I would say that for the veterinary students, when we have a calf come in, they often have cryptosporidiosis. And we will definitely tell them, you know, you might want to put on a mask, make sure that you wash really well after you've touched the calf, because that is the one agent that quite readily goes into veterinary students. It's self-limiting, but while you have it, you think you're going to die. But there's certain ones that we know might expose us to something bad, but typically they're not things that we're not going to survive from. And then I want to thank the people from occupational health and just the process of getting us TB tested and making sure that we came back for our retest and then actually followed up. It's sort of interesting on the follow-up. If you do react to it, you do go in for a chest x-ray, and then the public health people actually review your case and your chest x-ray if you've reacted, and then come up with a protocol of what you should do. I had something else to say about that, but it's sort of like gone across my mind here. Oh, I know what it is. So knowing that that's what the protocol is that they take a chest rad, and that this was M.bovis, do you think maybe the chest rad wasn't the best way to tell if you have an active infection or not? I did start worrying about it because most of the cases of M.bovis are extrapulmonary, and they were taking a chest rad. So maybe that's not the appropriate thing to do. I know that's probably in their protocol, but it did make me pause and wonder if that's really what should be done to follow up when you're a reactor.
So one of the things that I would like to mention is Dr. Whalen was in here is that this is a seminar in partnership with Public Health. Dr. Whalen is an advanced and eminent tuberculosis doctor. Confess that it's only TV and
So maybe you can come down
but
here.
I think he can come down and maybe help with some of these questions.
Yeah.
We can have a panel and some discussion. This is recorded, so we'll have some more information about it.
Bucky, if I could add one thing here, maybe you mentioned I missed it. One thing we did immediately after we identified the organism and we linked to Turkey is that we sent messages to all the veterinarians,
Right.
the diagnostic lab, and to the state veterinarian. Because part of our job is surveillance. And if, for example, if this animal had not come to us with additional golden retrievers out there, it could potentially expose others. So that's part of our job, part of our disease surveillance mission. So it's actually good to catch some of this. because
Yeah,
we didn't.
and we actually did follow up with a veterinarian that submitted it, and they had been apparently these turkey imports from this Adopt a Golden place, they were bringing in like 20 dogs a month sort of thing. And then this one, what I could gather, this one clinic was actually doing the exams on them, and they actually had another dog that actually had paniculitis. And the dermatologist that they sent it to said, well, you know, turkey has tuberculosis, and I don't know what happened to that dog or if they traced back to see if it actually had tuberculosis or not. So, yeah, that's a good point. Yeah. So the question about extrapulmonary.
Right. So I'll say a few words about.
Yeah.
Okay. Okay. I'll say a few words about tuberculosis in humans, and I'll speak initially about Mycobacterium tuberculosis, which is the major pathogen in humans probably in the last 100 years, though turn back the clock, there was a mixture of tuberculosis disease from M.bovis and M. tuberculosis. So first, M.bovis, Mycobacterium bovis, and tuberculosis produce identical diseases in humans. You can't tell them apart on physical examination or laboratory tests apart from culture sensitivity and identification. I would say that extrapulmonary disease is much more common with M. bovis than with Mycobacterium tuberculosis. So, but in the work that we've done in Uganda, where TB is endemic and M. bovis is present in animal populations, almost 100% of the TB that we see is M. tuberculosis. We don't see much in the way of M. bovis, and they will drink unpasteurized milk and be very close to animal populations. So there's something about the transmission of M. tuberculosis airborne route that seems to be in humans more efficient than M. bovis, at least these days. The reduction in M. bovis in the U.S. really began when we started pasteurizing milk and controlled the drinking of cow's milk and reducing the contamination of the cow's milk and ingesting the disease in that way. Now that's M. tuberculosis, airborne route, mostly pulmonary disease, some extrapulmonary disease. When you do see M. bovis in humans, it will often look the same. You would think higher in the differential diagnosis, the presence of M. bovis if there were lymph nodes and whatnot. But it would be you'd really need to know the surveillance and epidemiology of that strain of mycobacteria in the population where you worked. And that would help guide figuring out whether a lymph node enlargement is due to MTB or M. bovis. Looking at hospitalization, nosocomial exposure to TB, M. tuberculosis, it's almost always associated with some aerosolization of the organism. So it's been identified, there have been transmission events occurring in surgical settings when they do nasal aspiration in the intensive care unit or in bronchoscopy suites. One of the key diseases to exclude before you do bronchoscopy is active tuberculosis, because you do put everyone else at risk due to the aerosolization that might occur. But there are some unusual circumstances where TB has been transmitted through in an autopsy suite, where somehow the organism was aerosolized and it infected all the pathologists in the room. And no one developed TB disease, but everyone, when they found out that this was M. tuberculosis, they had already been exposed and many of them infected. There are circumstances where MTB has been people have kind of had a subcutaneous exposure or contamination of an open wound that have gotten M. tuberculosis in that route. I think M. bovis, and for transmission to humans, I think it is more common. I mean, I think an oral intestinal route might be more likely than an airborne route. In Uganda, I know that there are cases of tuberculosis that occur in the slaughterhouses, and they do find M.bovis in the cattle in Uganda, and there will be cases of M.bovis TB in the cattle in the slaughterhouse workers.
And do they usually have a pulmonary form? Or?
So it is usually pulmonary. They often will have extrapulmonary manifestations, though. I wouldn't say that's a common phenomenon. I think even if you were to, I think even most TB in those workers would still be due to M. tuberculosis, just because it's so common in the community. Transmission from other animals to humans, I couldn't find very much about that. Of M. bovis. Now, humans can certainly infect animals with MTB.
Right.
So it's one of the diseases that they test for before you go gorilla trekking in Uganda. So.
First, I don't know if you heard what we did in the presentation, there was people exposed, and one reactive case.
So one reactive meaning positive skin test?
Yes.
No
positive
disease?
skin. No disease.
Okay.
And we don't know if any of the students actually went. So
Was the initial skin test positive, or was it 6 weeks later?
6 weeks later.
So you converted?
Yeah.
And that individual had a skin test within the past several years?
Well, so immediately we went and we all got skin tested, or at least everyone suggested to go get skin tested. And then we were told to come back 6 weeks later.
But prior to that immediate test, had that individual been tested within the past year or two?
I don't know.
I don't know for sure, but I think so, because she would have had to get a visa. She's actually foreign, so I think, to come in the country. She's not vaccinated.
No BCG scar?
For a boost effect.
I believe you only need to make TB test if you're trying to apply for citizenship.
Yeah.
Yes, I don't think it's for
Actually, I'm a foreign student from the US. They will test you. It can be positive. You still let you in, but you have to have X-ray to show your health.
I don't know for sure whether she was. It was my impression she was. I know we did check because the country she was from vaccinates for TB, but in her case, she's indicated she was never vaccinated. She was negative.
And she didn't react on the first immediate.
Well, in the human health care setting, when an individual begins their work in an institution, we would call it a two-step test. And that's because some people do this. May have been exposed as a child, may have had a remote exposure. Their reaction to the birth of the skin test may have waned. And by administering a test, that antigen can be sufficient to bolster the response. So we'll test them initially, then about 2 weeks later, retest to see if we have a boost effect. If that second test is positive, and they don't have a clear exposure within that 2 weeks, if that test is positive, then most likely their exposure was in the remote past. So if this individual had been exposed as a child or some other time when their birth and skin test result had, as we would expect, become negative by adulthood, then what you may be seeing is a boost effect. I would ask Chris, it could have been a boost effect.
So,
In that case, that's one question. The other question I have for you, Chris, is regards the IGR, the interferon gamma release assay. I know that'll look for antigens to human TB and to marinara, I think, in fish. I wonder if it also involves
Yeah, so that's so a couple of questions. One, booster. So as Dr. Forehand mentioned, booster is a false positive initial test, but within 2 weeks you have a reaction on the skin test. And we just completed a study in Uganda looking at the booster effect. So just to put the setting, it's that we did about 150 people who were all skin test negative by tuberculin skin test. And by negative, we mean less than 5 millimeters. Most of them were 0. And they were all HIV negative in addition. Then we skin tested them 2 to 3 weeks later. And we had a conversion or a booster effect of about 1%. 1%. And we've hunted far and wide for that kind of population data, and it's just not out there. So this is a setting where virtually everyone had BCG vaccination. It's a setting where there is ongoing TB. The estimate of tuberculosis, M. tuberculosis transmission in this area of Kampala, you won't believe the annual risk of infection is 15%. I mean, that's 3 times higher than the highest I had ever heard of before. So there's a lot of exposure going on, a lot of opportunity for exposure. Nevertheless, we didn't see much in the way of a booster effect, but very high new infections. I think it's interesting that they reacted to a tuberculin skin test, and did they do an interferon gamma release assay?
Not on that person. One person did get that assay done, and they're immunosuppressed, but they were negative.
I said beforehand, I think you know, but we're participating in our health program. Dr. Forrester, our health doc, managed this case, and I asked him if he had an interferon blood test, and his point was the skin test was very positive, extremely positive, and he did feel it had value, that even if it's negative, he would say she still needs to get worked up for active TB. That was we asked him the question.
How positive was it?
I can't give you the exact diameter.
Yeah.
I just know he said it was, I can't give you the adjective, but it was extremely positive. She showed it to me several days later, and it was still like the necrotic center.
A necrotic center. Oh, wow. Yeah, I've only seen that once. And it wasn't a large 25 millimeter reaction. It was very, very impressive. So, boy, and hearing that makes me think temporally it's associated with exposure to the animal and conversion, but that size of a skin test would make me worry about real M. tuberculosis, infection, and that somehow there's a coincidence going on.
You wouldn't have expected them, though, to have reacted on the one that they went first at?
Well, I mean, booster is a possibility. I can't imagine booster that big or that strong, but I mean, they are from a foreign country. I mean, it may be coincidental that they were exposed to MTB around the same time as their exposure to the animal. I would just, as a internist, I would get a chest X-ray on that person. I would do a history for exposure to Mycobacterium tuberculosis. Anyone with TB, have they been in a hospital? When did they travel? When was the last time? Those sorts of details, just to make sure. Now, having said that, there are forms of BCG that are very reactogenic. So I don't know if BCG is Bacille Calmette-Guerin. It's the vaccine that's used for TB, given around the world, not in the U.S. and most industrialized countries. It is a form of M.bovis that was generated over 100 years ago with continual passage through a certain type of broth culture. And what Calmette and Guerin noticed was that the BCG became less and less virulent in animal models with rabbits. And so they were actually thinking, interestingly, along the lines of smallpox, that with smallpox you could take cowpox and inoculate humans and prevent smallpox disease. They were thinking, well, maybe we can take BCG, inoculate people with BCG, you know, an animal tuberculosis, and prevent human tuberculosis. And so that was the model that they were working on. So they passaged over many times. And what was interesting was there's a long history to BCG, but the long story made short is two world wars, followed by poor, I guess, laboratory practices, and the dissemination of various strains of this vaccine throughout the world at different times means that when we talk about a BCG vaccine, it's actually, if you look at the BCG given around the world, and did genotyping on it, would be different, all very different. But one thing they have in common is that there's a set of genes from that are missing in the vaccine, BCG vaccine, that are present in M. tuberculosis. And what I don't know is in wild type bovis whether those genes are still there. I would imagine that they are. So this is CFP10 and ESAT6 that give the interferon gamma assays their specificity against BCG. If bovis still had those genes, then I would expect the skin test to be very reactive and the blood test also to be reactive.
Question for you, just a general question. My understanding of course, you know Fred Quinn well, and of course he believes that TB is the most important infectious agent in the world. And it is, right, the most common cause now of mortality, morbidity, mortality in humans, is that correct? Bypass HIV?
Within HIV, yeah, TB has always been the main cause of death.
But if it's this common worldwide, and we've got as much time as Americans spend on aircraft with people from all over the world, would a large number of us be positive for TB if we were all to go get it?
Well, some numbers. In the U.S., the incidence of TB, actually any form of TB, is 3 per 100,000. So actually it's less than 3 per 100,000. In Uganda and other parts of Africa, where the rates are the highest, it can be as high as 1,000 per 100,000. So extremely high. And where I happen to be working, this rate, we had a rate of about 800 per 100,000, and we're seeing 15% new infections. Even if we discount some of those for boosting, it's still going to be around 12 or 13% new infections. So a lot of transmission. So airplane travel is interesting. And the CDC has done a wonderful job mapping out risk of tuberculosis infection on airplanes. And the take-home message from the few studies that they've published, the longer you're on the plane, the more likely you are to become infected if there's a TB case on the plane. That's number one. And number two, the closer you are to them in terms of seating, the more likely you are to become infected. People in first class don't get infected by the people sitting in coach. So, yeah, probably vice versa too. But the other thing, now I am no aerobiologist or aero engineer, but the airplanes, they have filtering systems. They have UV light, so all the air goes through a filter. And that filter has ultraviolet lights that would kill tuberculosis. And apparently they're able to circulate the air in sections. So I don't know how that is accomplished, but different portions of the plane, even within coach, there are several different circulations going on. It's fairly complex then. If you may be sitting across the plane from someone who has disease and is coughing, but given the circulation patterns, given the filtering, given the UV lights, and given the duration of time on the plane, the longer you're on the plane, the cutoff is sort of like 4 hours. More than 4 hours, they start to see people popping up with positive skin tests. How long were people in contact with the animal?
Probably a minimum of 2 hours.
2 hours,
Yeah,
maybe longer?
potentially.
Uh-huh.
Yeah, but probably not more than 4.
Yeah.
Can you say about the most likely kind of exposure with the striker was turned on?
Well, that's what we assume because it's aerosolizing things, but there were so many organisms in that liver. I would think that, even a splash from that might have had more bacteria in it than aerosolizing something with a striker, but I don't think we'll ever know.
Just like you said, normally you expect to see rare as best bacilli are defined. In this case, it was more likely to see maybe.
There were too many to count. It was very scary, to be quite honest, the number that were there.
Was it confluent in the liver?
The
the-
infection?
Yeah.
Grossly, it looked multinodular, but really when you looked at it, most of the liver was involved with these coalescing areas of necrosis.
Yeah. Sorry, I was late to miss them.
Was there any abnormal texture to the liver or the lymph node when you sized? Did it have that sort of plastic grittiness?
No, it wasn't mineralized. And I don't know if on ultrasound, if they had seen mineral in it, if they would have thought something like tuberculosis. I doubt it. We just don't see that kind of thing in a dog. So this was liver acid fast stain.
Wow.
Yeah, wow. I think that's when I started to get scared.
Yeah.
Many of the mycobacterial diseases we have in animals, is hard to find the organism unless it's M. avium in a bird. We'll often see a lot, or unless it's a seahorse. And this was a granuloma in the kidney.
In the kidney.
Yeah, the kidney was, and this is the leptomeninges. And the kidney had multiple granulomas in it, which you could actually tell were granulomas. But this was a hepatic lymph node.
Were there giant cells left?
What's that?
Were there giant cells?
In the ones in the kidney? Not really, they were mostly epithelioid macrophages. And so the liver was mostly these coalescing areas of necrosis and some inflammation, which was more lymphocytes and plasma cells.
So it looks like cavitary disease in the liver. That's what it looks like it's formed.
Oh, I see what you're saying, yeah.
In the lung, that's what you see. You see these large granuloma that eventually necrose and they cavitate, they coalesce, and then you have the person coughing out the contents of their cavity.
So that's a hepatic lymph node. It doesn't have any mineral in it. It's just basically a big necrotic mess. And then this is the liver.
I'll say that when I was in medical school, my cadaver had lots of nodules in the liver that turned out to be granuloma.
Oh,
so
really?
she was an older woman who probably lived long before treatment, when TB was fairly common in the U.S. and before there was any treatment. So she didn't die of tuberculosis, but you could see evidence for it as we examined the different organs. Nothing like that, though.
No, this is pretty impressive.
Yeah.
So I have a question just about that quantiferon test.
Yes.
And back to that question about if M.bovis is extrapulmonary. Is the interpretation of the quantiferon test sort of a on or off, yes or no, or is it gradated? And so would that be a way to monitor somebody and pick up something that was extrapulmonary? Would the quantiferon assay go up if the person were to develop active extrapulmonarism?
Yeah, so the quantiferon test is an in vitro skin test, really is what it is. And it's You draw the blood, and what you're doing is haphazardly sampling the blood, and you're drawing out cells, and you're testing whether any cells in that sample have been sensitized to M. tuberculosis by exposure to antigens, CFP10 and ESAT6 antigens in the test tube there. So then you incubate for 24 hours, and you test the supernatant for interferon gamma. You measure interferon gamma levels. There are a couple of problems with the test in that the optimum and peak expression of interferon gamma occurs in 72 hours. So you're sampling this usually at 24 hours, possibly even before there's been a peak or response to it. The other is you're going to pick up precious few cells that are sensitized to M. tuberculosis in any blood sample. So there's a lot of variability potentially variability from sample to sample. You're not incubating it long enough to get the optimal level of interferon gamma. Now, I know the manufacturers and the developers of quantiferon, interferon gamma test, they've been balancing the utility, the practicality, with the test in a clinical setting versus a longer test, because in 2 days you'll have a skin test result back. What good's an interferon gamma test if it takes 2 days? You want it faster than that. So that's part of the thinking behind the development of the test. So it is an ELISA of the supernatant. So it is a continuous measure, and they do come up with a threshold level above which they call positive, below which they call negative. But where they set that threshold is, to some extent, an arbitrary activity. They're trying to optimize at what level they put that threshold to improve and maintain the sensitivity and the specificity of the test. So what you're asking, so let me introduce another test. It's called the TB spot test. And the TB spot test is pretty much an in vitro skin test. And it's almost identical to the quantiferon test, but instead of measuring the expression of interferon gamma in the supernatant, it takes the blood sample, you spin the sample, and you take the buffy coat, and you put the buffy coat that's exposed to MTB antigens on an ELISA plate, and then you incubate it, and then you stain the plate with a counter stain to interferon gamma, and what you wind up doing is counting the cells that have interferon gamma fluorescence. So it actually counts the number of cells that are ramped up to express and produce interferon gamma. So the TB spot is counting cells that are expressing interferon gamma. The quantiferon is actually measuring the amount that makes it into the supernatant during the 24-hour incubation. And the skin test is the in vitro, is in the in vivo functional test.
I have another question. Being in type infection, it's likely to go in vial, maybe that number of organisms. Do you think it's completely blocked and contained within the liver, or do you think you might have something in feces, for example? You have some organisms.
I think very much it could have been coming out in the feces in this particular. I think it could have been in the feces in this animal.
Because my concern is transmission to owners and other people that should handle this animal means such a massive infection.
Yeah, because the involvement of the kidney is interesting. So obviously the immune. And urine will aerosolize, even dry urine will aerosolize.
So what I'm thinking, I'm not sure if the exposure might not just only involve the people people doing the necropsy, but the owners and the veterinarian that attended to this animal, the circle might be a little wider than the thing. And she said maybe this is not the only case, and we are reporting.
Yeah.
Yeah, and I don't know what they did about the other dogs that were imported in this group, if they looked at all of them. Maybe they were all gone by the time I don't know.
Yeah.
I have related to your question or comment. You mentioned in slaughterhouse, they might be infected in slaughterhouse foreign countries. So in the U.S., we have a lot of meat products from foreign countries. So it could be more in the meat. It's kind of, if we eat them, kind of transfer us, or maybe they keep them frozen. Is the frozen step can kill the bacteria?
No, I wouldn't think it would kill the bacteria at all. Heat would. Exposure to ultraviolet lights would. But so that's really an interesting food safety question. I don't know the answer to that. How how and where we import meat from, and what regulations we have for the safety of the animals, prior to slaughter.
As far as I know, USDA don't test the TB routine meat products.
Yeah.
I think that it was originating in countries that have inspection service equivalent to the U.S. Whether that actually happens, that's the rule. Like Brazil right now, it started importing beef into our country. The concern there is putting out we're allowed to do it because we have comfortable with the level of food inspection.
Yeah.
That's theoretical.
And another comment is for you mentioned the CDC. I mean, also wondering the requirement, the permit you need to import any animals from other countries. CDC requirements under USDA, there's the Animal and Plant Health Inspection Service, APHIS. They actually regulate any animals, even plants from foreign countries.
Well, probably not dogs and cats. Cattle, yeah. Sheep and that sort of thing.
I can speak to both of those just a little bit, but yeah, so FSI is the Federal Food Safety Inspection Service. For countries that we are importing from, they usually have regional offices, and they will typically do some kind of spot inspections, a port inspection of slaughter plants, abattoirs overseas. And then here at home, they are routinely submitting samples primarily from cattle, but also from sheep, goats, and hogs. We will occasionally get different types of mycobacteriosis, primarily again in their GI tract as well. So we do some routine surveillance in that manner. So that's, again, it is related to equivalency, but they do have a mechanism to try to spot check, I guess, the level of the degree that we're maintaining, that foreign countries maintaining an equal program to emphasize this program. And then CDC is the regulatory agency for importation of pets. That's their role. They do, there are certain diseases that USDA is concerned about, so they'll, you sort of have to meet those requirements as well. But ultimately, you also are meeting the entry requirements for whatever state you're bringing the pet into. So there's sort of three agencies that you have to be mindful of when you're importing a pet.
Yes.
Bruce, I have a question for you on the evaluation of the veterinarian who were using the Department of Public Health algorithm protocol for assessment. It is simply history, fever, night sweats, blood cough, weight loss, and the chest X-ray. It doesn't necessarily include, an exam for abdominopathy, asthma, or other findings that you might need skin that you might discover. In the patients I have seen in Athens with active TB, which are not many, fortunately, one was extra brown, and we thought just had moment in the clinic turned out that in biopsy 7 weeks later it was extra brown TB. So in this case, M.bovis, was very little more likely to be extracorporeal without the pulmonary component. Wouldn't you want to expand that physical assessment and get going maybe with this person look a little more deeply than just that chest X-ray and view systems?
Yeah, I think so. And this gets to
And
a point that,
the relevance being, is it active TB or is it latent?
Yeah.
You can treat, which treatment protocol is
right, exactly. And it also gets to something that's going to lead a question that I have for you all, and that's the index of suspicion.
Mm-hmm.
And you know, here in the U.S., we have such a low index of suspicion for TB in humans that you know it's easily missed and would be commonly missed by your average doctor and you know in the community. They just wouldn't think about it. Mono got swollen lymph nodes. In Uganda, first thing on the differential diagnosis would probably be HIV. And depending on if it's an adult, it would be HIV and then TB. And but here we wouldn't think about TB till long down the differential. I think the proximity to exposure is an important issue in the evaluation of humans who might be exposed to M. tuberculosis or M. bovis, I would imagine. Because the risk of TB disease is highest soon after infection. And by soon, it means, you know, within the first 6 months, and the peak kind of is at 1 year even, and then it seems to go down after about 2 years, it starts to drift down. So 2 years after the initial infection with M. tuberculosis, and I might assume M. bovis, would be the highest risk period that we would know for the development of active pulmonary disease or extrapulmonary disease. So I think given that the nature, we don't know necessarily the nature of the route of infection, whether it was inhalation per se or whether it was some sort of contamination and through the GI tract, we really don't know. And Fred Quinn and I go back and forth about infection with M. tuberculosis. Is it really airborne? Because most particles that people cough out are fairly large particles, and when someone breathes those in, they impact in the upper airways. And what people then do is swallow that. And then they go to sleep at night, and we all aspirate a little bit of our gastric contents at night. And where does primary TB occur? It occurs in the very lobe of the lung where we aspirate to. And that gives rise to the primary pulmonary TB, which can go undiagnosed, unrecognized. And then shortly thereafter, that's when you get the dissemination, and that's when it seeds the upper lungs for reactivation disease. So Fred and I, in fact, we're working on the ferret animal model as a way to try to figure out whether there's a mucosal colonization phase prior to infection. So it's a way out idea, but someone's got to ask the question. But so that answers the first question. The second one was about therapy. Yeah, clearly you need to differentiate M. bovis from MTB in terms of directing therapy. So, I mean, preventive therapy, isoniazid may not. And right, and isoniazid may not do anything to M. bovis. You know, the isoniazid may not do anything for M. bovis, and you might need to choose something else.
So what would be the protocol typically if you were exposed and you react, but you don't look like on your chest x-ray that you have active disease? What would you do preventative treatment too? And so with M. bovis, what would you do?
Yeah, with M. bovis, I would treat it as a new infection, as if it were M. tuberculosis. I mean, in the absence of anything else, that's in a human. That's how I would approach it, because it can produce disease, extrapulmonary, can produce pulmonary disease as well. But I would err on the side of prevention than kind of watchful waiting. So,
just to clarify, if you had on the case they were describing where you had a reaction on this like sleep test, you would go ahead and treat?
as long as the person didn't have any signs or symptoms of active disease. So Dr. Forehand, okay, chest X-ray would rule out a pneumonia, or so that's step one. I think in that case, a physical exam to look for lymph nodes. I would have, with a big reaction, I would do axillary lymph nodes to see whether that lymph node was also large and reacting. In children, sometimes children get the BCG scar, or they get BCG vaccination, and it's very reactogenic, and they'll get, you'll see them develop lymph nodes here, and sometimes they'll even ulcerate. But then it will heal on its own over time. But I would err on the side of caution in someone who's acquired a new M.bovis infection. And yeah.
So if any of those were positive, you would do more than just
I would. I would treat them for drugs. Yeah. I mean, they may feel fine. In our work in Uganda, it's amazing. In household contacts, we were routinely doing cultures from household contacts, all of them, and many of them say, "I don't cough." We'd say, "Well, just spit into the cup." We'd give them a little aerosol for a few minutes, and then they would be able to cough something up. But it was usually it just looked like spit. Grew M. tuberculosis. And they looked fine, they felt fine, the x-rays were normal, but we found M. tuberculosis in their sputum. So we're wondering, it raises all sorts of questions about the pathogenesis of TB, and that's where the idea of colonization came from for me. But I guess my question is during my residency training and fellowship, the hospitals began to adopt a universal precautions protocol, where and this was in the face of the AIDS epidemic, and the thinking at the time was, make an assessment, and if you think someone has the disease, then use the appropriate precautions. The problem was that all depends on physician level of suspicion. And just a personal story, I was working in the emergency room. I got a call from one of the HIV docs in town and said, "I'm sending in patient John Doe. He has end-stage AIDS and has a cancer of some sort, and will you take care of him?" And I said, "Sure." So half an hour later, someone rolls through the door, looks like a cancer patient, looks like an AIDS patient. The name was not John Doe. It was someone else. And so in we go to work on this fellow, and John Doe never came because that was John Doe. He just he gave a different name to the clinic and I was waiting for John Doe. So I didn't put on any gloves when I was taking care of this patient. And consequently, I had blood all over my hands, come to find out it was an AIDS patient. And so my level of suspicion is a clear example of not how to behave, and that led to this universal precautions in hospitals. So you'll see signs. Folks working in healthcare settings will have universal precautions. Is there anything like that in the veterinary side?
Yeah, I mean, I can address that. The answer is yes, for the most part. I mean, our concern is not the ones you know about, it's the ones you don't know about, right?
Right.
So we do universal precautions with the exception of N95 masks on every case. As you can appreciate, they have all our students and everybody in the respiratory protection program versus the risk probably not, it probably doesn't make sense. But everything else, safety glasses, gloves, aprons, we do automatically across the board now because of that exact reason. You don't know what you have. Now, when we get into high risk, we talked about that earlier, we get into more of we have additional precautions. In addition to that, we've gone to increase precautions automatically anytime we use a striker saw. Anything's going to aerosolize. So we've steadily over the last 2 years gotten more and more, inserted more of this. Probably 8 years ago we weren't doing the first precautions across the board. We are now, only exception is masking.
So that's
Right.
right.
When veterinarians is a patient, I'm not sure when they don't know you.
I'm sorry. Is that what you're talking about? I'm sorry.
I think both things. So, a veterinarian will not be responsible to see a patient, and not sure if the disinfectant that will use will be effective against mycobacterium, if it was the animal was going to be urinated in mycobacterium area, so it's out. So that's something else. That's what we wanted to bring up partially, so we can discuss this.
Yeah, I mean, universal precautions it's not 100%, and you're right, it's for what you don't recognize and don't know, and that's why you do it. It's very hard to maintain because, I mean, the sort of mechanical things are hard to maintain, but after a while, people forget why they're doing all these things.
Well, that's why it's important when you have a case like this, you advertise it and you talk about it, because it sticks in your mind more. It's an opportunity, and we also brought in our biosafety office too to look at our procedures and processes in our facility.
Now, in I don't know whether they have it here at Athens Regional or St. Mary's, but I was involved in developing what was called a TB care pathway at the hospital in Cleveland that I worked at. And basically what that was sort of an extension of universal precautions. So a person walks into the emergency room and they were given a list of signs and symptoms that would remove that person from the waiting room and put them into a negative pressure room and given sort of instructions to wait there. And a physician or a set of nurses would go in to a negative pressure room, now with an N95 mask on, and obtain the samples, the specimens, and they would be fast-tracked up to the path lab where they would do a spot sputum test for acid-fast bacilli. And if negative, then they would relax the precautions and the person could come out into the regular waiting room or into an examining room. So it was a way for a respiratory disease like TB to be isolated very quickly in the healthcare setting. I don't know how effective it was, but I know I'm sure it's still in place. And again, how regularly it was adhered to and how fully it was adhered to is maybe another question.
That's a good point. And that's we have a room for that purpose as well. The problem we have is HVAC issues, making sure it's negatively outside, and we're working with that now because it's not. The problem with HVAC really doesn't. It's not negative to the hall or to the necropsy room because of the purpose.
When I used to make rounds, there were 2 or 3 rooms on the medical floors that were supposed to be negative pressure, and what I would do is I taught my residents how to test for negative pressure. You open the door about a centimeter, and you take a piece of tissue, and you just tear a little strip, and you hold it in front of the door, and if the tissue gets pulled in, you know that there's a negative pressure in the room. If it comes out at you, you know that there's a problem, you don't go in the room. And a lot of the TB problems of the early 90s, particularly drug-resistant TB, occurred in hospitals where the negative pressure wasn't working properly. And in a New York hospital, they had the TB ward just perpendicular to the AIDS ward. And it turned out that the negative pressure rooms weren't working, and when they did airflow studies, the airflow went from the TB rooms out down the hall and down into the AIDS ward. So that's why a lot of the transmission occurred.
We go to a couple, we use universal precautions. In all human medical facilities, pretty much universal precautions for bloodborne pathogens are mandated pretty much. And our accreditors check us very carefully to be sure that we do that. And in addition to universal airborne precautions are now pretty standardized and for certain cases. And we have, since the SARS episode back in 2003, 2004, built negative pressure rooms in our urgent care area. So we have 3 of them. They have urgent care monitors per room. So we would engage negative pressure. It's a little ping pong ball that goes in and out of this shoot, a little tube, but it's very visible. Everyone can see if it's working. But we'll use it, and we use it today. It's odd, we use it for chicken pox. Someone comes in, they suspect chicken pox because I don't know if any of our current practitioners, a couple of us, have actually seen native chicken pox. The vaccine is so effective, but it is very contagious. Or suspect measles, or suspect TB, and we divert them to those spaces. And we go in, as Chris said, within 95. In addition to universal bloodborne precautions, we use airborne precautions. CDC standards are pretty, delineated what that includes. We also use airborne precautions whenever there's potential for aerosolization. We don't decapitate many of our patients, take their craniums off, but we will use hyphenators and remove lesions that are viral etiology or lead procedure in our women's clinic that will create some smoke and potential for inhalation of HPV particles. So whenever we're creating smoke or vapor, use masks or shields. Shields are the movies.
Yeah, drawing on my Uganda experience, living on the equators has its benefits because most things happen outside. So the waiting room is outside in sunshine, so you'll have 100 TB patients all sitting, gathering around, but they're sitting usually in bright sunshine. There is a problem when you bring them into the examining room because there's nothing negative pressure. It's an old TB sanatorium, and the wards have huge windows on both sides, so there is always a cross breeze. And for what it's worth, I've worked in those wards for many years, and I'm still skin test negative. So, but having, I think having a place to put suspect animals and suspect humans for airborne or highly infectious diseases really makes good sense, and having a protocol to do that.
This has been a fantastic discussion, and I really enjoyed this forum. And maybe some of you in the audience, if you can have some other ideas or things that we can discuss with our partners in public health or medical partnership, so we can have like a true discussion and we'll learn from each other through one health history. That would be fantastic. And we have people that are working, and we pass our hour, so we really have to let them go. But if we want to keep talking about this, we should. And remember to send us ideas for additional One Health seminars. Thank you very much for listening.